All right, hello everyone, and thank you for attending today's webinar on new rules for sharing employee health information. My name is Jeff Donnell, and I'm president of Enterprise Health, and I want to welcome everyone to today's session. This is actually the 10th in a series of webinars that we initiated last year in response to the COVID-19 pandemic. Although I'm happy to say that today's session is really the first one that won't center around COVID, which is actually a very encouraging sign in many ways. Also happy to report that we have more than 275 individuals who've registered for today's session. So we really appreciate all of you making time to attend today. Just a few housekeeping items. We're muting everyone upon entry except for our moderators and panelists so that we can minimize background noise. I do want to point out that we are recording this session, and we will email everybody early next week with a link to access the recording, and feel free to share that more widely in your organizations. We're very pleased to have another fantastic panel today. It's a group of legal and occupational and employee health experts, and we've asked each of our panelists to make some initial remarks about their observations on today's topic, and then we'll open it up for a Q&A session. You can actually submit questions via the Q&A feature in WebEx, and we'll certainly get to as many as we possibly can today. And our panelists include Stephanie Eckerle, who's with the law firm of Krieg, Devault, Dr. Kenji Saito, who was with MedLaw, and Emily McComb, who is with Enterprise Health. So before we turn it over to the panelists, I'm going to provide a little bit of context on our organization as well as today's topic. And now that so many of us are vaccinated and we're starting to ride in elevators again, I'm going to give you the Enterprise Health elevator pitch, which you'd be forced to hear if you were unfortunate enough to find yourself stuck in an elevator with me. So we're the only cloud-based health IT solution that combines occupational health and compliance, clinical care, and employee engagement on a single, interoperable, certified electronic health platform. And our focus is on equipping enterprise clients and their employees for a healthier future. And we work with mostly blue chip global organizations, government agencies, as well as hospitals and health systems. Most of our clients are operating their own on-site employee health clinics, and in many cases, they also provide third-party employee health services to other organizations. We're going to start off, we want to be very upfront today that we're going to be trying to do a little bit of reading of the tea leaves. The focus of today's webinar is around some new legislation in the United States that actually went into effect last week, and it governs the practice of sharing electronic health information with individuals. However, it's not yet entirely clear if and to what extent these new rules are going to extend to employers who are providing occupational and employee health services to their workforces. So our panelists today are kind of relying on their experience and expertise to gaze into the crystal ball, and they'll certainly provide you with some valuable context, their sense of how this will shake out, as well as their thoughts on best practices. So we can't promise that you're going to leave this with complete clarity, but we're confident you're going to get some very valuable information and insights to certainly start the ball rolling in your organizations as you have discussions on this topic, with people who are interested in policy and legal matters. So just to give you a little bit of history, the U.S. Department of Health and Human Services created the Office of the National Coordinator for Health Information Technology many years ago, and I realize that's a mouthful. And the original acronym for this office was ONCHIT, which led to a lot of inappropriate jokes. So today it's actually known more simply as the ONC. So the ONC was created really to help promote and coordinate the adoption of health information technology by healthcare providers. And really when this group was started, adoption of electronic health records by most in at least the U.S. healthcare industry was around maybe 15%. And they have been very successful because, now we're getting closer and closer to 100%. And really what drove a lot of this was back in 2009, stimulus funding was approved by Congress in the wake of the 2008 financial crisis. And a big chunk of that $900 billion package was used to fund health IT adoption. So to qualify for that funding, healthcare providers had to do a couple of things. They had to deploy a certified electronic health record, and then they had to comply with what were called meaningful use rules to demonstrate proper use of those certified EHRs. Now, at that point in time, which goes back a ways now, I know I was deeply involved in electronic patient engagement. And I actually attended some of the early hearings that the ONC hosted as they were drafting these meaningful use rules. And I went to these hearings planning on advocating for the concept of making electronic health information available to patients. And I quickly realized that I could stay in my seat because there was a sizable group of individual consumers who showed up, and they were extremely vocal about the need to include the patient in the equation. And they argued quite successfully that their health information belongs to them and they should be able to easily get access to it. So as kind of an early pioneer in the electronic patient engagement space, I know our organization, along with others, did a lot of pick and shovel missionary work with physician practices, hospitals, health information exchanges, and employers. And there was, I have to tell you, a significant amount of early pushback, especially among clinicians, to the concept of sharing electronic health records with patients. And I recall many heated debates with physicians who were dead set against sharing things like electronic lab results with patients, especially without building in some sort of a delay period for physician review. And most of them said, hey, I'm worried that I'm going to get that midnight phone call from a patient who got a lab result and doesn't understand it, and I don't want to have an onslaught of those sort of things. But invariably, those same clinicians would come back after 2 or 3 months and say, you know what, now that we've done this, I'm going to give you the green light to go ahead and share the lab results without delay, let the patient have them the same time that I get them, because they realized that their worst fears didn't come true. And in fact, in most cases, patients who had more access to their data were more active, they were more involved, they were more compliant. Now, certainly it changed the nature of some of the conversations that clinicians had with patients, and they would actually do maybe more pre-counseling to say, hey, we're going to do this lab test. Here's the kind of results that, that we're looking for, and if you get this kind of result, here's what it may mean. But after you get the results and I've had a chance to look at them, we'll get together, we'll talk about it. So it actually led to, in many cases, better, more meaningful dialogue. Now, despite, the gains that we've seen in the adoption of electronic health records and other health information technology, the healthcare industry is really probably the last remaining market sector that still struggles a great deal with interoperability. Health information is still far from being extremely liquid. And for years, the HIMSS conference, which is actually the major gathering for health IT professionals, and it attracts more than 40,000 visitors a year, they've hosted what's called an interoperability showcase, and that's what the picture of, that you see on the screen now. And the idea was to demonstrate how data could flow between disparate health IT systems. And it was sort of a, hey, here's what could happen if we could make all this work. Now, the fact that HIMSS has been putting on this massive demo year after year for now well over a decade to show what could be done, what might be done, only underscores how far we still have to go. In an ideal world, they would have done this for a few years. It would have all been worked out, and there'd be no reason to have this showcase anymore. And we used to participate in this event, but frankly, we grew frustrated because we would demonstrate interoperability with all these other vendors, only to have those same vendors afterwards say, oh, that's just a trade show thing, or we haven't productized it yet. And, to add on to that, historically, many healthcare providers weren't overly interested in making it easy for patients to take their data somewhere else. And many health IT companies and EMR vendors were notorious for what came to be known as information blocking. And ultimately that resulted in many EMR vendor CEOs having to get up in front of Congress and explain themselves as to why they wouldn't make their data more liquid, including making electronic health data available to patients. And as a result of that, the requirements around sharing and not only among healthcare providers, but sharing data with patients, they've grown more and more stringent over time. And today, significant penalties are being meted out to healthcare providers who actually fail to give patients timely access to their data. I know my brother's father-in-law passed away last year from complications from COVID in a nursing home. And when they asked for a copy of his medical records, the nursing home dragged their feet, and they said that the legal team at their corporate office had a policy against sharing those records. So I advised my brother and his wife to threaten to report this to the ONC, and miracle of miracles, the next day the records were produced. But this sort of thing, that reluctance or outright refusal to share data with patients happens all too commonly. And it's one of the reasons that the new legislation we're discussing today has beefed up provisions for sharing information with patients. So while we still don't know the full impact of these new rules in terms of how they apply to occupational and employee health, it's pretty clear that the information sharing train that has now been boarding for more than a decade is starting to pull out of the station. And it's going to create real momentum for deep and wide information sharing with patients, or in the case of those of us on today's call, with employees. So while you may have some trepidation and some very legitimate concerns, I know I can speak from experience that an individual who has access to and more involvement in their health information is far more likely to take a more active role in not only their health care, but the health care of their family members. So with that as a little bit of background and context, we're going to turn it over to our first panelist. And our first panelist is Dr. Kenji Saito. And Kenji is President and Chief Medical and Science Officer at MedLaw. And they provide OC and environmental medicine consultative services to companies, professional organizations, hospitals, and clinics. And he also serves as a medical leader for regulatory agencies, consumer goods, and transportation industries. Previously, Dr. Saito served as a medical director for an OC Health Services clinic with multiple locations in central Maine. And he's currently president of the New England College of Occupational and Environmental Medicine and vice president elect of the American College of Occupational and Environmental Medicine. And Dr. Saito earned a dual medical degree from Temple University and a law degree from Rutgers Law School. And Kenji's going to really help us illustrate some of the challenges and confusion that we're seeing in OC Health around this topic, as well as talk about some best practices on information sharing. So Kenji, let me stop sharing here.
Great. Thank you, Jeff. Well, good afternoon, everyone, and thank you for joining today. I think we're going to have a really fun time. I want to make this talk very interactive. So for those of you who are in front of a computer, if you have a cell phone, it might be a little easier unless you have dual monitors. And there's a QR code here. You can go to, just put your camera on and put it over the QR code, and it should take you to the website. Otherwise, if you want to stick on the phone browser or your computer, you can go to polev.com/medlaw. I'll go through a couple slides of just introductory, so you'll have some time to log in, and we're going to make this a live polling and interactive talk, because I really like to hear from everybody in the audience today. So before I get started, I'm sorry, the lawyer in me always wants to make sure that you get full disclosure, sort of what background I'm coming from, the conflict of interest I have, and certain disclaimers that I have, since this is more of educational purposes, and these opinions, especially are thoroughly mine and not necessarily those of my employers and clients that I work with. I do have a lot of images here as well. I do not necessarily have permission to use all the images. I'm sort of invoking fair use here, just for purely educational purposes today. So a little bit about me. I am a dual physician and an attorney, and luckily I found passion of mine in sort of nutritional sciences as well, and so well-being is that I'm also a sushi chef. So I kind of balance it out, being a physician, a chef, a lawyer, and luckily found the field of occupational and environmental medicine where I'm actually able to practice all three. I get to go out and pretend to be different workers and different settings, different sectors, whether it's out using a skidder, being a scientist, flying a plane. It's been an exciting time and I really enjoy it. And I hope that I'll be able to share some of my experiences, especially from a hospital setting where I used to work in a clinic base, whether it's a near site or on-site clinic, in the corporate world, looking at corporate medicine and how do we set policies, benefit plan design and whatnot, and sort of being a consultant and private practice solo practitioner. So been juggling everything. So I'm kind of bringing those experiences with me in addition to some of my governmental experiences, rotating and working at central office of the VA through OSHA, NIOSH, EPA, ETSDR, and the Surgeon General's office doing some public health work too during my training. And I'd love to share that experience with me. So let's see if our polling is up and running. It should be activated. I'm curious to see where everybody's coming from, so I can hopefully tailor this conversation towards where our needs are, whether you're in a healthcare setting, providing maybe a third-party employer or insurer through a near-site on-site clinic, whether you're in corporate, any government folks, and there's a few others. So mostly healthcare. Great. So I'll gear my talks towards mostly healthcare, but also incorporate some of the sort of corporate policy perspective as well to make sure everybody's understanding of that. And for those of us in healthcare, are you a nurse, an NP, PA, physician, MDDO, maybe other clinical support staff, technician? Are you an administrator, perhaps doing some non-clinical work? Just get a better idea of where you're from and sort of your background here. So most of us are nurses here. Great. So I'll try to gear towards some of the nursing staff, which is I presumed maybe COHMs running different clinics, understanding what these rules are. So I'll be able to explain that as well, and some decision makers here in administration. Perfect. So this is a word cloud. I like to start off with this because this is a brainstorming session as well. So why do you think information sharing is important? Is it due to some process that we need to understand and the philosophy of why information sharing is important? Yes, the continuity of care. I think that's really important to understand. And I think Jeff talked about this briefly, about the idea of interoperability, meaningful use. There's sort of the philosophy behind why we need to understand information is important, especially when sharing with the patient, is not only engagement, but also be able to provide good, high quality care. And to do that, I think impacts us in very different ways, and engaging our patients and making sure to understand what we're prescribing for them really does affect patient care, their experience, their engagement. But at the end of the day, outcome as well. So I think it's really important to understand why different agencies now are trying to regulate, the more importance of not blocking information, because we want to make sure there's transparency, there's exchange, and there's interoperability between different EMRs as well. And this is why I think the idea of electronic health information is so important. And as Jeff mentioned, we are kind of looking to a crystal ball because we're not really sure where this is or if there's any unintended consequences from these rules. But I think it's at least understanding the why behind it helps understand this the process that needs to occur to get to the why. So thank you for this. So I think you're right. It's focused on patients, transparency, continuity, engagement. So do you routinely share health information with your patients, employees, claimants? So it seems like most of us do. So the question then becomes, why is it important that there is an information blocking rule now? So there was a survey that just came out last month, that just published last week, looking at 4,000 healthcare entities and the clinical technology and administrative leaders from providers, payers, ITs, and other organizations done by Life Image. But I'd like to sort of benchmark what we're going to do today. So the questions they asked, I think, is quite relevant. So let's see the questions they asked versus how we respond. So overall, are you familiar with the term of information blocking? Do we know what that is? So we're fighting there, almost 50-50, 50-45, 60-40. So yeah, I would assume that it's around 50-50, right? And this is why we're here today. And most of us do not know what information blocking, and this is probably another reason why you're here today. And Stephanie will definitely go into more of the details of what the definitions and meanings are. But I think it's important to understand it's out there, terminology exists, and that a lot of people are not familiar. 47%, which is close to where we were. We're a little bit higher, but the survey participants actually said they were not familiar with the idea either. So what is the primary exchange method that you offer to your to the employees that are asking for this information? How are you sharing that information to them? Is it paper, CDs? Do you have an online portal? Are you emailing it securely, hopefully? Great. So it seems like we have some sort of online portal. So it makes the access a little easier. the process and methodology might be easier. So probably the question we'll focus on today is, for those of us on paper, what does that mean, especially now it's requiring electronic means, and how do we transition from paper to some sort of digital format, and then to online portals. So let's see what the results of the survey showed. So 66% basically relied on paper. So I'm surprised, we're pretty close, and then it went down to 40% for us. Majority relied on CDs. So I think this is looking at some of the imaging as well. If you look at the PAC system for the MRIs and CTs, X-rays, I think a majority of them answered that reason too, because most of them still offer CDs. And I haven't seen an online portal like a PAC system where you can actually look at images quite yet for the patient portal side. But yeah, I think the portal is the way to go. And the majority of healthcare institutions, do not have that capability, but we're hoping that'll be the case soon enough. So if those of you who do offer, do you charge for your patient records? I know this became a big issue, especially from a business perspective, when we had a lot of people requesting records, and especially when you do paper. I'm curious to see what you do charge, and I'll be happy to share with the survey results too, to see where the benchmark is. Some states offer, especially if you're making records, a copy of records that you can bill for the expenses of that. So I think some people do charge patients, but it looks like a majority of us, especially those in the portal where patients go in and download their images, you're not charging anything. So that's good news. Hopefully I'll make Stephanie happy. So survey says 15% currently charge $25 or more. So I know there's like 4% or so that charge about that much from our survey here. So the good news is it sounds like most of us have portals, and most of us are actually exchanging data through that method. And that's why there's almost no cost to be able to do that. And this is exactly what the ONC rule states. However, there are some exceptions to this, right? So if you look at the final act, at the bottom right there, I highlighted that it should be offered in a structured or unstructured manner, but at no cost to the patients and to your employees that are accessing this right now. So I think that's really important to emphasize. But as any kind of regulations, there's always exceptions to it. And I'll leave this to Stephanie to talk about more, but there is a fee exception where you could bill. However, there are purposes that need to be met. But the recommendation, I think the best practice here still is to be able to provide it at no cost to the employee, and prevent any hurdles that you might have, especially for those who cannot have access to their own personal records. So I think that's really important that we do that. So have you or your facility made any changes to meet all the rule requirements? Especially those of us doing paper, have you done anything? Or maybe you don't know because you're not part of the decision-making process. I know we do have a couple administrators on the call today and an audience. So most of us don't know whether we made changes. So that's probably the other 50% or so who say that we don't know much about information blocking. So hopefully after today's talk, we'll at least be aware of what the rules are, and then have some guidance as to what best practices are before some of these rules are challenged or solidified into our regulatory framework. So most of us don't know. So survey says 48% are not aware. So we're pretty much on target here with that, the cohort of 44,000 employees that took the survey before. So exactly. So this is why we had this webinar today, and we have a lot of registrants as well. But also sorry, I missed one survey. So another survey that I was going to ask was whether there is any penalties assessed for any kind of wrongdoing or information blocking practices. Sorry, I know the survey didn't pop up here, but the results did show that about 39% did not know that they could incur civil penalties associated with this. So it is a rule with some teeth. So keep that in mind. So what happens if you or your facility does not share health information with your patients? Oh, well, here it is. I guess, sorry, that information came first, but I guess most of you know now. Good, we're paying attention. I guess that's a good test. I did that on purpose. So I wanted to go through some hypotheticals now too, especially this is relevant to the occupational health realm is, do you normally release workers' comp injury records when requested? Interesting. Almost 60-40 of us do not. Okay, here we go. So some of us do. And we can save this for Q&A towards the end as well after you hear about information blocking from counsel. I'm just going to go right afterwards, Stephanie. How about post-offer pre-placement exam records? What are your thoughts about that? So a little less. Okay, so most of us said they would. About 30% would say they wouldn't. Interesting. How about surveillance exams? Like exams are required by OSHA or other people who come in routinely or periodically for different surveillance exams. Do you think they should get those records as well? Whether it's the physical exam component or the results of those blood work that you probably do for biomonitoring? Okay. So it seems like most of us agree that we should release these records as well, and you are releasing it. How about DOT exams? The Department of Transportation for federal commercial motor vehicles. Good. So everybody knows, that you are supposed to here as well, and it's actually in the regulations that you should provide these exams. And in some cases, employers do have a right to some of the copies of the exam itself as well. This has been controversial in the past, but the FMCSA does have recommendation and guidance on this as well. How about audiograms results? Any kind of hearing loss or standard threshold shifts in or without the hearing conservation programs, do you normally release those records to the patients as well? Okay. So it seems like most of us would, or actually all of us would so far that's responded. So yes, that's helpful, right? Because especially if you have any conductive or neurosensory hearing losses, you definitely want to make sure they get follow-up care because, we're not the PCP or primary care provider in the occupational health clinic. So it's always nice to make sure that they have a good follow-up to whether it's an ENT specialist or with their PCP to continue following whether this is an age-related hearing loss or any other perspective as well. How about spirometry? For those of us who used to do them and maybe starting to do them again now, especially during COVID, are we releasing the spirometry records to the patients? No, looks like we're having some technical difficulties with this one. Perhaps it got locked up. Okay, that's fine. My suspicion is if you're going to release the audiograms, the question that becomes is why wouldn't you release the spirometry records, especially for those who are following the asbestos, silicosis standards and whatnot, whether there's a requirement for you to release it or not. And some of the information and best practices here is also to provide that to the patient, especially if there's any concerns for any obstructive or disease processes that you see that are constrictive as well, that restrictive as well, that could potentially be helpful if their PCP knows about it, the patient knows about it and aware that they need to seek some care, at least to get a baseline documentation. You'd be surprised how many people have sort of borderline asthma and or other lung disease that they never knew about until they had a spirometry done and referred them to get a real PFT to be done with some of the specialists to follow up in their care. And this is an interesting question. How about drug screening results and records? Yeah, so most of us do not release these, or okay, we're going back and forth. Do we release them or not? The battle for the 50s. So this is why I left this question for last, because it's quite an interesting question is, are we required to? Some of these are done without any kind of surveillance component to it or a regulatory component, but more of an HR policy component to it. And it comes to really interesting labor and employment bargain for labor questions, but also employment law questions as well, what the employer can and cannot do. So we're almost split here. So this is what OSHA says, right? So there's the standards for 1910.1020 is access to employee exposure and medical records. And if you want to look up this link, it's the bottom left here. It does indicate and provide employees and or their representative with access to relevant exposure and medical records. So there's a huge definition. Maybe we can talk about this Q&A if you're interested. For the sake of time, I want to make sure that we leave Stephanie enough time to talk about her component. But the exposure is the question, is whether that drug screening is an exposure or not. Some places do not. So I always look at this as a balance between what your risk perceptions are and how do you manage those risks. And I don't know if you've seen this imaging before, but I think this is a really helpful concept to understand is hazard is something that can potentially cause harm. But when you're looking at risk, you have to look at the hazard and exposure. So what kind of exposure do you have by not doing this, by not following the rules? And for example, drug screening, what do you do if you don't provide it? What kind of hazards are there because of that? And that's how you manage your risk. And I think at the end of the day, we need to go back and look at the idea of what and why we're doing this. So I think by doing so, it makes us understand the importance of why we need to be able to offer these to the employees, but also to their designated representative at OSHA. And let me see if we can stop sharing so I can see the chat screen real quick. Yeah, and feel free to type in some chat questions, but I think we're going to save some questions towards the end. And I can't see my screen now. There we go. So it looks like I don't see any questions in the chat right now. But yes, the idea and the transparency behind information sharing is very important. And I think we have the data now to show you what we're doing in an occupational health clinic and best practices around information sharing, even though it might not be required, especially those of us in paper. I think we really need to focus on priorities here. What do you need to do to transition? Because the idea of transparency, exchange, interoperability, sort of philosophy behind why information sharing is so important. Sometimes it's better to do the right thing first rather than having regulations tell you what to do. I think in those cases, it'd be great to be able to do that. So, Jeff, should I answer some questions now, or do you want to save it towards the end? So while we're waiting for Jeff to come back on, let's see. Assuming all requests include proper signed release, some exams such as IMEs are owned by the requestor and not the patient and should not be released without the client's consent. Yeah, so that's actually very state dependent. So that's a great question. What do you do for IMEs? In different states, there's different regulatory frameworks. That usually sits under the workers' comp board if you have one in your state. Otherwise, it's somewhere within the Department of Labor, because as we all know, workers' comp is very state specific. So depending on those IMEs coming from requests from the workers' comp board or their attorneys in those litigation or cases, it's important to understand what your state laws allow for, because the federal laws only give you the minimum standards, and then state can raise that bar a little higher. So great question and correct.
Hey, Kenji, I think what we're going to do is go ahead and pass it over to Stephanie, and that way we can, we'll have time for questions at the end.
Sounds good. Thanks, everyone.
All right, and so next up is Stephanie Eckerle, and Stephanie is an attorney and partner at the Krieg Devault law firm, and Stephanie provides regulatory compliance and corporate advice to the healthcare industry, and she specializes in working with employers that provide occupational and employee health services at on-site clinics. She's also on the board of directors for the National Association of Worksite Health Centers. And right now she's working with a number of organizations as they come up to speed on the 21st Century Cures Act. So she's going to dive into some of the specifics of the Cures Act and other legal and regulatory requirements. So take it away, Stephanie.
Great. Thank you, Jeff. Can you see my screen and hear me okay?
Yes.
Awesome. Okay. Well, thank you, everyone. And Jeff, I really enjoyed the introduction about ONC and the history there. I consider ONC the health IT, highway. And then Kenji, I really liked the polls. I'm going to have to remember to do that on future presentations. So I'm going to dig into the nuts and bolts of sharing employee health information today for you guys. So a little bit about me there, if anyone's interested. I think the slides will be provided sometimes afterwards too, so you'll have my contact information if you guys have follow-up questions. But before we dig into the information blocking rules, I really want to talk about, the puzzle that is employee health records. I think it's a really complex area from a record-keeping standpoint. And so whenever, I start working with a new organization, whether it's an employer or a healthcare provider, we don't even dig into the law at first. We dig into, let's unravel this puzzle and figure out what laws we need to be looking at here. And so, for example, you may have an employer that has an occupational on-site health clinic, but also provides primary care at that clinic. And they may also provide EAP services at that clinic. So there, you're going to have a huge overlap with different regulations. And so I put together the questions I ask when I'm first starting to work with new clients, that kind of inventory that you guys should all be thinking about when you're trying to figure out, where do I even begin here? So I won't go through all of these, but just a few here. So, what type of health services? Again, is it OC health, non-OC health, primary care, workers' comp, mental health, substance use disorder through the EAP? That's all really, really going to matter. Who are the services provided to? Is it just your employees? Or do you guys also wrap in dependents at an on-site clinic or minors? This is going to have a lot of implications, again, on what laws you guys are following in addition to plan design and benefits. Who pays for the services? Are we having the employer pay because it's occ health related? Is it workers' comp? Or do you have a primary care clinic where you are also billing third-party payers like an Anthem? And I've even worked with a few clinics recently that see retirees, so you get a Medicare population in there, although that's a little more unusual. So all of these questions are really what you need to go through to try to unravel and figure out what you're looking at. So once you do that, you're really needing to think about what I call interlocking and overlapping requirements. And so I listed a few here of the regulatory frameworks and agencies that we're thinking about on the legal side. So you've got OSHA, EEOC, ADA, ONC because of the new information blocking rules. And we've got SAMHSA because of SUD and EAP records. So, lots of laws here that we're going to need to consider as we unravel the puzzle. And one thing that we're going to be providing afterwards is a resource list that's going to have the various laws and different opinions from agencies linked in it. And so you'll have that too after this, sometime after this seminar for reference. Okay, let's talk about information blocking. We could have an all-day seminar on all the other requirements, but we're here today because of this specific law, the information sharing, the interoperability, all this that came about, not just because of the 21st Century Cures Act, but historically HIPAA and HITECH and others. So why should you care about information blocking? Well, under the new law, information blocking applies to all healthcare providers. And this is defined very, very broadly under the Cures Act, so in the regulations. It includes physicians, practitioners, therapists, hospitals, federally qualified health centers. I mean, you name it, it's included here, although a few aren't, maybe like an industrial hygienist. I didn't see them on the list. And when you look at the term physician and practitioner, you think, okay, of course we know what that is, right? But I want to point out, because this is a question I'm getting a lot, it is any doctor of medicine, it is any PA, any NP, clinical nurse specialist, social worker, registered dietitian, nutrition professional, are just a few, and it does not depend on if that physician is billing a third-party payer or if that, physician is enrolled in Medicare or Medicaid. So it would encompass the occupational therapist too. But, one question is my clinic a HIPAA-covered entity? The information blocking rules do not differentiate based on a covered entity or business associate status. So I've also heard this from some employers. We just have an occupational health clinic. It's not a covered entity because we are not billing any third-party payers here. And so it's really important to understand that the information blocking rules do not differentiate based on that. So you can just have an occ health clinic, and as long as there is a physician in it, that physician is a healthcare provider. They do not have to be a covered entity or a business associate. And this was actually addressed in an ONC FAQ that said an individual that meets one of these definitions is an actor and subject to information blocking regulations, regardless of whether they're a covered entity or a business associate. And so, again, we will be sure to give you those FAQs and this resource list that we will be providing. Okay, another question I'm getting often is, but I only maintain occupational health records. Again, I don't think this matters. What I was really hoping before I gave this presentation is that we would get some guidance from OSHA on this, but unfortunately that has not happened yet, nor have we gotten guidance from ONC on how this would apply to occ health providers or occupational health records. So in light of that, we look at what type of records are affected by the information blocking rules. Well, before October 6, 2022, electronic health information, or EHI, is limited to the subset of data represented by the elements in the US CDI standards, and we'll link to those too. But that is going to be very broad. It's patient demographics, problems, procedures, clinical notes, which includes, your consultation notes, history and physical imaging, lab reports, path reports, immunizations, medications, allergies, and intolerance. So when you think about your occupational health records, you're going to include these data elements. And then after October 6, 2022, information blocking regulations apply to all EHI as defined in the regulations here. And that's really any health information you would find in a designated record set. Okay, so now that we've talked a little bit about who this applies to, your healthcare providers, and what type of records, know that you cannot engage in information blocking. And what is information blocking? That's a question we get a lot too. And I'll tell you, we're getting this question not only from our occupational health clients, but also, frankly, from health systems, from physician practice groups. It's a concept that some people are very knowledgeable about, but frankly, as I think Kenji's survey showed, a lot are not. So if you're one of those, don't feel bad about it. So information blocking is a practice that is conducted by a healthcare provider, again, defined very broadly. The provider knows, so you have to know, that such practice is unreasonable and is likely to interfere with the access, exchange, or use of electronic health information. And so it's a really, really fact-sensitive inquiry here. This can result from individual actions, corporate policies, contracts, or even technological limitations, which is why we're really encouraging our occupational health and healthcare clients to work with their EHR vendors like Enterprise Health to understand these rules. Examples include, refusing to respond to a patient's request. So just like what Jeff said with the nursing home example, just outright refusal, and we do see that. Another one, refusing to share clinical information with a competing provider. That has been an issue in some cases in the past, and one of the reasons that ONC passed these rules is to really, keep innovation alive, lessen competition among providers. And so, you cannot refuse to share just because someone else is your competition. Or you cannot share only because someone, is competition, and so you're going to make it expensive or inefficient. You can't request a patient consent where no patient consent is needed. So just going through, all the different ways that information blocking can apply to different situations. Unless, there's an unless there, unless an information blocking exception applies, which we're going to get into here. Okay, so if a request for access is denied, an information blocking exception absolutely has to apply, and all elements of it must be satisfied. And so when you think about this, we're going to go over these and some of the elements, but you really need to understand every element and have documentation of why you are meeting every element if you are not going to give a patient access. And think about the overlapping laws there, right? So if you are a covered entity, not only must you follow the information blocking rules, but if you deny access to a patient, you also have to follow the HIPAA rules for denial or the OSHA rules. We're really recommending that healthcare providers develop a process and policy to evaluate requests and then have documentation to demonstrate why a request was denied. And so that documentation can be in the EMR or on a separate form. So let's dig into these exceptions now. Okay, so I categorize these two different ways. One is denial of access. So if you're going to deny access to records under the information blocking regulations, it has to be for preventing harm or due to privacy, security, and feasibility or health IT performance. And then there's three exceptions that don't really go to denial, but it goes to how you fulfill that request. So how the content of the request, the manner, the fees, and the licensing. So let's spend just a little bit of time today talking about these. And again, I'm not going through every element of these, just kind of the main points. So you can deny a request for access to records in order to prevent harm. So to meet this exception, it has to be to substantially reduce the risk of harm to the patient. It has to be determined on an individualized basis by a licensed healthcare provider who has a current or prior clinical relationship. And I put document again. You need to document these exceptions if you're going to rely on them. This is going to be really important because these rules were effective April 5th, and I have already seen a complaint filed against a healthcare provider. Actually, the complaint was filed before the rules became effective, which was kind of funny. But I've already seen complaints, and I think it's going to be a new area of litigation that you're going to see a lot of activity in, and you're going to see a lot of, I think, companies trying to get patients, and in your case, employees, to file complaints on this. So one thing to think about with the preventing harm exception from a practical standpoint, again, is that overlap with other laws. So for example, if you have a occupational health or you're providing primary care on site in Indiana and there's mental health records involved and you think that the mental health records need to be withheld from the patient, you have to comply with the information blocking rules, but also Indiana's law on mental health records. And under that law, you have to determine for good medical cause upon the advice of a physician that the information would be detrimental to the health of the patient. And so, you know, unlike the information blocking rules where you just have to be a licensed healthcare professional in Indiana to withhold those medical records, you have to get a physician opinion. And so, again, it's all about those overlapping requirements and understanding what laws apply to you. You know, you have to, if you're a covered entity, follow the procedures for denial to access that are laid out. And then under OSHA, again, another example of these overlapping laws. OSHA has a standard in 1910, 1020 E2, if you'd like to look that up, that says whenever an employee requests access to his or her employee medical records and a physician representing the employer believes that direct employee access to those records regarding a specific diagnosis of a terminal illness or a psychiatric condition could be detrimental to the employee's health, the employer can inform the employee that access will only be provided to that designated representative. And so again, another example of the information blocking rules, OSHA, state law, and HIPAA, and how they all have standards that are just a little different. So I think one, you know, complex thing here is going to be harmonizing all those standards and creating a really, you know, concise and clean policy that pulls all those together for your clinic. Other exceptions here, and then we're going to get into some real life examples that we've been working through with clients. The privacy and security exception. So you can deny access to records if the restriction is required by and the denial is consistent with state or federal law. So if your employee requests records, but you do not have to provide those, let's say, because they're EAP records and they're governed by Part 2, which is what governs substance use disorder records, or there's a provision in OSHA that would allow you to deny access, you may be able to deny that under the privacy exception here. And I think that one, you know, it's going to take a while to see how this plays out from an enforcement perspective and how these all are intertwined. Security, another one. If the restriction is related to safeguarding the confidentiality of the EHI, or there's a specific security risk that you believe could occur if you give access, that's another reason you can deny access. But again, it has to be based on specific facts and circumstances. And backtracking a little, all of the exceptions, it's an individualized determination based on every single request to access. You really cannot do a blanket denial for any of these. Every single time, you've got to go back to the drawing board if you're going to deny and look at the individual facts. The next exception we're going to talk about is infeasibility and health IT performance. So infeasibility, if you are going to deny access maybe because of an uncontrollable event, your natural disaster, your war, your terrorism, or probably more common here is an internet service interruption. So this may not be something where you deny records, you know, forever, but it may be the patient or employee calls, wants the records immediately, and your internet is down, the portal is down, you can't get to them, so it's a temporary denial. Another one, though, is the inability to segment electronic health information. So maybe you can't segment the part of the records that would be detrimental to the physical safety of the patient because they're intertwined in the report that primary care practitioner created. you could potentially withhold all the records. Health IT performance is another one. If the health IT is temporarily unavailable in order to perform maintenance or improvements, there's an exception for that, but it must be for a period of time no longer than necessary. And there's additional requirements, restrictions there for the health IT developer. Okay, moving on. So Kenji did a nice job of framing this, the response here. So when we think about the information blocking exceptions, we talked about how you can deny, but then we also talked about how you have to fulfill a response. And so under the information blocking rules, you must promptly respond to the request. There can be no unnecessary delay. And I think this is going to be a tricky one for providers and employers. And the reason, again, is that overlapping requirement. And so under HIPAA, for example, a covered entity, a healthcare provider that is a covered entity has up to 30 days to respond to a request from a patient. But under the information blocking rules, you really need to immediately respond unless there's a reason to deny access. And so even though that physician may be able to wait 20 days under HIPAA, they can't under the information blocking rules. And same with OSHA. Again, another example of these overlapping requirements. Under OSHA, you're supposed to provide access within 15 days. And if that's not possible, then the employer within that 15 working day period has to apprise the employee or the designated representative requesting the record of the reason for the delay and the earliest date when the records can be made available. So again, really harmonizing all these requirements is going to be, a big job. Okay, content and manner, talking a little bit more about this. So, the manner, you have to provide the records in the manner requested under the information blocking rules. And so if you were able to upload those records via a portal or send them via email, and that's what the patient wants, you cannot send that patient a box of their records. That would be information blocking. However, if you cannot fulfill the request in the manner requested, there are alternatives under the information blocking rules to fulfill that request using a certified EHR or other alternative machine readable formats. And fees, again, Kenji, I was really excited to see your poll on that one. You set that up nicely. So you cannot charge for electronic access to EHI. Just do not do it. And I noted here, just knowing the audience, that that's similar to OSHA's requirement that records need to be provided without cost to the employee upon the initial request. And there's some other exceptions there, under all the different regulations, but that is absolutely a best practice. If the employee says, I want paper records and it's 5 boxes and there's time spent on copying and mailing, I think that's a bit of a different situation, but any electronic access you should not be charging for. And the contents. The contents of the response must be based upon the request. You cannot try to artificially limit that request or not respond fully unless that exception applies. Okay, let's move on to some hot topics here. Okay, so routine lab results and test results. This is the #1 issue I think that we get questions about and that we're dealing with. So the information blocking rules do not require a healthcare provider to proactively make the EHI available, but once a quote unquote request is made, you have to timely respond to that. And what's tricky here is that ONC has not stated what a request is. So, a good example is I get blood drawn at the doctor and I tell the person drawing the blood, or I tell the receptionist on the way out that I want those test results as soon as possible. And so if that's the case, the provider, whether it's a physician, nurse, whomever, has to push those results out as soon as they have them. And what this could mean, and this has been acknowledged by ONC, is that you are going to have patients or employees that may be getting test results or lab results prior to the ordering provider seeing and interpreting those results. Under the information blocking rules, you cannot have a blanket delay of several days that allows the provider to first review test results. So if a request is made, we can't wait 10 days to allow the provider to review those results before giving them to me unless an exception applies. One exception that could apply is the preventing harm exception. And what ONC has said about this is that, that physician is already going to have, or nurse, whomever, is already going to have a relationship with the patient. And so they should proactively determine whether there is a risk of harm that meets that exception, document it, and that will then allow you to delay the results in order to allow the provider to review them. But again, you have to strictly comply with that. Two important things, moving on, psychotherapy notes. So we talked about what type of health records are included according to the information blocking rules, but two types of records that are not included are psychotherapy notes as defined in HIPAA. So notes by a mental health professional that are kept in a separate file from the regular records. And the second type is records compiled in anticipation of litigation. So one of the things that Kenji talked on was there's a lot of HR implications here when you think about not just the information blocking rules, but OSHA record rules and rules under the ADA and the EEOC about employer access to examinations. But one of those things is if it is documents prepared in anticipation of litigation, it is not subject to these rules. Mental health records, we talked a little bit about the example of the difference between Indiana law and the information blocking rules as far as that preventing harm exception. So those are a really, really sensitive type of record you need to think about. Substance use disorder records. So I bring that up here only because of the issue of the EAP programs. If you have an EAP program that provides substance use disorder treatment and holds itself out as doing that, it may very well be subject to 42 CFR Part 2, which is substance use confidentiality requirements for the SUD records. And, just remember that the information blocking rules don't replace Part 2 or any other law. They just all go hand in hand. The last two things I'm getting a ton of questions on, one of those is clinical notes. And so what ONC has said about that is that draft clinical notes are examples of data points that may not be appropriate to disclose if there's a request for access. But if such notes are used to make clinical decisions, they would fall under the designated record set and be included in the EHI you have to produce. And so, really I think the question I'm getting a lot is, I just want to document progress notes to remind myself, is what the physician or nurse may think, and I don't ever want the patient to have access to those. Well, that doesn't really work anymore. It doesn't work under HIPAA's right to access, and now it doesn't work under the information blocking rules. So if those progress notes are part of the record and you're making clinical decisions, they have to be included in that request for access. And the last one is the HIPAA authorizations. I'm just going to touch on this briefly, especially knowing how many healthcare providers we have on the call. And for those that are HIPAA covered entities, maybe they're running a primary care clinic on site and billing for that. The information blocking rules also touch on the HIPAA authorization issue. So if you have a patient bring in a HIPAA authorization that maybe actually isn't compliant with HIPAA, they pulled it off the internet, it doesn't meet the strict requirements of HIPAA, you cannot just deny access anymore. Now, under the information blocking rules, you have to make sure the patient gets a HIPAA compliant authorization in order to release those records. So again, just that overlap there. So what now, right? This is overwhelming. It's overwhelming, I think, to attorneys, to healthcare providers. So what do? One, work with your EHR vendor. And I put Enterprise Health up here because I know that they have worked very, very hard to understand the 21st Century Cures Act, both on the health IT side due to the certification, but also, the information blocking rules and how they can really assist healthcare providers in compliance. And so work with your EHR vendor, whoever that may be. Review and update your policies. You may need a new policy, or you may need to amend current HIPAA policies or OSHA record-keeping policies. Provider and staff training is key. Your frontline providers and staff are the people who need to understand this just as much as the administrators and back office support there. Because when that patient leaves the clinic and tells the nurse or tells the the receptionist or the physician, hey, I want those lab results as soon as possible, that needs to somehow get to whoever is handling request of information, especially if you are not proactively pushing results out on a patient portal. And then lastly, monitor ONC and OSHA updates and guidance. Again, we are waiting to hear from OSHA on this. I don't know whether they will speak out on this. And I actually attended an ONC webinar and asked about the applicability of these rules to occupational health providers and in the occupational health sector, and there was no response on that. So keep monitoring updates and guidance. And again, the resource guide or page we're going to give you after this presentation will have links there where you'll be able to go back and check for updates. Okay, and if you have questions, I know we're going to have questions at the end, but also feel free to email me or, reach out. Happy to chat with any of you. And then just like Kenji, I have my standard disclaimers at the end of the PowerPoint. Okay, thank you.
Great, thank you very much. Appreciate it. Our final panelist is Emily McComb, and Emily's responsible for customer success at Enterprise Health. She leads our account management and application support teams. So she's going to touch briefly on some of the capabilities of the Enterprise Health application to support sharing information with employees.
Thanks, Jeff. So using the employee portal, many of our customers actually have already kind of started down this road of making some configuration changes. I will say for our Enterprise Health customers on the line who are curious about what your colleagues who use EH are doing, most of them are taking a proactive approach rather than on a one-off basis per request, sharing information only as requested. Most are wanting to automate this. And so we've been working with some of our customers to kind of fine-tune what those automations look like, and we'll talk about that a little bit more here in a moment. There is a lot of flexibility around those controls and what is shared so that you do have the ability to sort of blanket rule out certain things like case management notes and such, and we'll talk about that again in a moment. And then for those of you who are not familiar with the employee portal, it does work great on a desktop or mobile device, so you do have some flexibility there in how your employees are accessing that. I know for many of you who work with unions, cell phones are out of the question, so there are kind of non-mobile application options for you also. So on the employee portal, we do have two primary ways that we are helping our customers satisfy these requirements. The first is through the Message Center. And the Message Center is essentially a collection of documents that come directly from the patient's chart. So for Enterprise Health employees, this will be quite familiar to you. You may have documents such as clinical summaries from your visits, proof of vaccination, which is becoming all the more popular these days, lab results and such. And when the documents become available on the employee portal, you can see from the last screen here, there was an INR on this example of this test chart here. This is made available to print or to view, and then the employee can follow up as needed. You're going to see I did this intentionally. This goes back to clear back to 2010. You will have some control on what you would like to show here if you would like to cap some of that information sharing. You certainly can. Stephanie, when we get through Q&A, I would love to know your thoughts on, for employers taking a proactive approach, if you have any recommendations on how far back they should be proactive. I'd love to hear those thoughts from you. But an employee can, get this information in a proactive fashion where when a new test result or imaging report or something like that is put on their chart, it can be made available automatically on the portal without a physician or clinician review. The next area we're going to look at is the My Medical Information section. Part of what you'll need to consider is that, yes, visit summaries are important, lab results, imaging reports, that type of thing. Those are certainly important. But routine information like their immunization history, allergies, medications, those can all be called into question as well, and things that an employee could request. And under the My Medical Information tab, we have a few different configurations of this. The option that I'm showing you here shows kind of the basics: immunizations, allergies, meds, and conditions. And it shows it to you here in a completely view-only format. So the employee can see what is on file for, say, their medication history. They're taking a daily aspirin. They can't interact with this data, though, but we do have an interactive version where they can actually modify the information that's out here so they can keep their medical records up to date between visits with you if you want that option. And you'll have that option kind of per section as it is. So if you want them to be able to, you know, disclose that they've had a COVID vaccine, but you don't necessarily want them to modify their medication history, you have an option per section to be able to let them modify that. That certainly doesn't speak to the information sharing side of things, but as you use this to leverage patient engagement and employee engagement, that might be something that you would want to consider. There are good questions coming in from the QA, so I think we'll open it up for these folks here. And I'm sorry, Jeff, I'm going to have to stop sharing my screen to get back to the QA, which I'll help moderate here. The first one's from Tammy. Great question. And she asks, are you required to provide drug screen results? So that's the first question. She's kind of two in here. Specifically asking drug screen results paid for by the employer. Stephanie?
Kenji or Stephanie?
I'll have Stephanie go, and then I can chime in what practices are, because I'm not sure what's the legal ramifications for that.
Yeah, okay, sorry, I was muted. Can you hear me now?
Yeah.
Yep.
Okay, perfect. Yeah, so this is a completely lawyerly answer. It depends, but let me try to go into that a little more. So we've run into this issue. Let's say the employee goes to a med check clinic to get a drug screen, right? Or goes to an outside provider to get a drug screen. The issue you're going to have there, and that we've seen, is those providers have their own obligations to provide access to the results to the patient. So, you know, that whoever's doing it may be subject to the information blocking rules, or maybe subject to some other law that would require allowing access, such as HIPAA. So unless there is a law that says you do not have to give access, then I think you would have to. But I think the drug screen is going to be a really tricky one there, because there are certain situations where you do not want to have to give access. Another example we've dealt with for healthcare systems a lot is diversion of drugs. So we'll, you know, say the nurse or physician is caught diverting drugs. If they are drug screened, but it is part of the HR process, you know, I think under the information blocking rules, you could argue that was done in anticipation of litigation and outside of the health records. So maybe in that situation you wouldn't. So I think it's pretty fact sensitive there. Kenji, any other thoughts?
Yeah, I think this is very state specific too, especially if you're an employer in a state that has a Department of Labor based drug screening program, a policy that's required. For example, in Maine, you're required to have a policy that's passed by the Department of Labor in order to have a true drug screening policy within your workforce. So, and it stipulates there too, what the results go, how is it presented, and how it needs to be offered to the employee and the employer. So I would say, you know, it depends as well, and more so where your jurisdiction is, and whether you have a other jurisdictional agency oversight as well. So that's the reason why I asked the polling. It was 50-50, because it really depends. And it's challenging too, because I haven't seen any really good electronic chain of custodies even, because some people won't want to see that whole system. And sometimes I've seen it scanned in the charts the same way. So, you know, some of that needs to be parsed out, because that's not medical records per se. It's actually more based on processes and whatnot that doesn't need to be part of that medical record. So we have to be careful what's in the chart when it's scanned in haphazardly.
Great, thank you both. Question from Alicia. This came earlier in the presentation, I believe, Stephanie, before you started your presentation. She asked, given that the legislation is finally being treated as in effect, despite it technically being enacted previously, are there fines being issued for violations at this point?
Yeah, so two-part answer there. One, I want to address it under HIPAA. HIPAA, the Office for Civil Rights, which is the regulatory authority that enforces HIPAA, is on a roll on a right to access issue. They have now, I think, entered into their 17th or 18th settlement agreement and enforcement action with healthcare providers that are not providing access to patients. So if you do not provide access and you are a HIPAA-covered entity, or if you do not provide it under the OSHA regulations that we cited, you can get fined by those two entities. From an ONC perspective, under the information blocking rules, we just went into effect on April 5th. And so we have not seen any enforcement action there yet. And actually, I think from a healthcare provider perspective, They have not finalized what those fines are, but honestly, I would need to double check on that in the amended rules that came out a while back. I know on the health IT developer side, they have finalized those fines and penalties, and they're hefty. So again, I think enforcement is going to be, my guess, a ways out on this, just because since it just went into effect, you're just now going to start getting complaints, and with the investigation process and the fact-sensitive inquiry, it'll be interesting to see when the first one actually comes out.
And I would just add that certainly from a health IT developer point of view, I know at Enterprise Health, we're making certain that our technology is able to comply and support whatever our clients put in place from a policy point of view. So, we always kind of say that the technology is the easy part, that, that the policy is really where it gets challenging. But as our clients, kind of sift through all these regulations, and in some cases competing regulations, and the overlay that Stephanie mentioned, as those things settle out, we've got the technology pieces in place, because at the core of Enterprise Health is a certified electronic health record. So part of maintaining that certification is we have to be able to comply with these information blocking provisions. So that is all baked into the product.
Yeah, and Jeff, real quick, on that policy, I highly recommend occupational health providers or any providers have policies here. But just like Jeff said, that the policy is the hard part, that policy has to be able to be operationalized. And part of that is going to be really understanding how your EHR works and how your workforce and staff interact with the EHR and what the workflow is there. Because I've seen policies that people just like copy and paste from the regs. Great start, but you've got to incorporate the actual workflow in order to make it really meaningful. And that means understanding your EHR and potentially even working with the EHR vendor on some of these issues.
That's a good segue, Stephanie, actually, to, Kenji, I'm sorry.
Just a really brief comment too. And I agree that, and I just want to emphasize again the importance here of the data elements too, because there's certain elements that can be disclosed and some that should not be. So you have to be very careful. And luckily, there's technology available now, and Enterprise Health has one, because I've seen it, is that you can select the different elements that should or should not be released, whether you want to release audiograms and not spirometry, or drug results, or not screening biometric data. I think it's really important when you write an operation as a policy is what should be and what should not be disclosed, and not just have a blanket disclose everything, because that is a little overkill and sometimes can be detrimental as well.
Sure. That's, perfect segue. So we have some customers on the line who are actually asking some kind of tactical questions about how we accomplish that. And we'll certainly get into the details with each customer, because I know we have a lot of folks on the line who don't use EH as well. But generally, just to throw out some quick jargon here for the EH customers on the line, it's really primarily through document type permissions on a specific chart tab called the message center. So for the different document types that we have in place for your different visit types, you're going to, say, include something like a routine surveillance visit, but you would probably not include documents for a case management encounter where you're discussing legal matters with a supervisor and that type of thing, or a case manager who's doing non-clinical work, which would not be, governed under this type of information, or this type of rule, rather. And then if you do have lab integrations in place today where you're receiving sort of a mix of sensitive labs like drug screens and maybe more routine labs like blood labs, CDCs, that type of thing. If you're concerned that those are coming through and looking too similar to the system, and we want to be able to parse those out, we'll work with you to put those filters in place so that we know when something more sensitive is coming in, so that we can easily identify that and isolate it so it would not go in an automated fashion if needed.
Good point.
So Stephanie, a question for you. Sorry, I just had it in front of my fingers here. What electronic version is acceptable? Is PDF an acceptable kind of electronic version of this data as it's defined in the rule?
Yeah, so great question. There's so many good questions I'm seeing here. I'll try to talk really fast. So, so the information blocking rules do not require you to use a certain health IT. So, when you think about electronic access, I think if you have a patient portal available, that is kind of the gold standard, frankly, because it allows you to push those results out immediately. But if the patient requests electronic information and the patient says, hey, I really want to access it through a portal, and you say, hey, we don't have a portal, you can still provide electronic access to that patient through a PDF. If it's going to be a PDF, make sure it's sent via secure email, please, or password protected, right? We still have the security regs here. So the rules don't require a certain type of, they just don't get that granular.
Okay, that's helpful.
And they do allow for alternatives too. So again, if it's, we want this type of access, it's not available, well, then here's your alternatives through another electronic or EHI method.
Okay, great. Another question about corrections to information. I think that's interesting. I can answer, you know, we won't spend too much time here, but I know we can request corrections be made to more material changes, like let's say, I don't know, someone keyed in the wrong medication, or I'm just not taking a medication anymore. We have mechanisms through the portal where someone can send a request for an update. But if they see a correction that's needed on, say, a visit note or something like that, Stephanie, does this rule govern, or Kenji, does this rule govern any kind of communication back and forth to say, hey, I would like to see this information changed on my record? Are there any implications or corrections around this?
The information blocking rules do not govern that. I mean, again, the provider can't try to limit access, or the provider can't say, I don't want to discuss this with you. But again, it's that overlapping legal requirement. So HIPAA does have separate regulations that govern amending patient records. So if you're a HIPAA covered entity, like your primary on-site employer care clinic, maybe that's going to govern. And then, you know, just think about the other laws too there, as far as, you know, are there separate regulations that you're governed by that would allow for amending or not amending. But information blocking rules, and Kenji, unless you feel differently, I don't think they specifically address amending records.
Yeah, no, Stephanie, I agree. They do not. However, from a best practice perspective, and I see a lot of this because of verbal dictation, like nuance or dragon, you know, there's errors that tend to occur. And especially if the error is detrimental in any way, it's good to have that amendment in there, because when it affects patient care or any kind of clinical care, and then there's going to be duplicated multiple times, it's good to have that amendment in there to clarify some of that errors, especially when it's a technical error because of a verbal dictation or a scribe error as well.
Sure.
But don't edit, because you can't, it's actually, I don't think most EHRs allow you to, once you finalize a note, you can't go back in and change it. It's usually amendments that to occur. So definitely check the policies and especially the regulations with HIPAA first.
Yeah, that's really critical. So don't go back and change it so it like never existed in the first place. You want to literally like amend it. So, because otherwise you run into issues from billing standpoint and litigation if there's ever a lawsuit. So amend, don't like delete and replace.
This is an interesting question, and this is going to be a difficult one to get into the technology piece of it, but we have someone in the gas and oil industry asking, how do we provide records to a representative, union or attorney, or a former employee that does not have access to the portal? So if one of you could speak to kind of how this extends to prior employment, I think that's interesting. The technology side of it is an interesting barrier because of access. You know, if they're just no longer employed, I think that's a particular use case for prior employees. Can one of you speak to kind of what the burden of responsibility is there from a legal standpoint?
I'll happy to jump in here first. So from a legal standpoint, again, information blocking rules technically are not going to govern whether it's a former employee or a current employee. And so you're going to need to provide those records electronically if that's requested. Now, again, it may not need to be the patient portal if the patient doesn't have access that way, but it may be like a secure and encrypted email or some other method. And so from an information blocking standpoint, I think that's really critical. But I think, again, and Kenji, you may want to speak to this from like an occupational health and OSHA standpoint, it's going to be a little different. And from an attorney or personal rep standpoint too, you're going to need to make sure that whatever law is governing those records, whether it's OSHA or HIPAA, that you have either you're allowed to provide those under that law, or you have the proper authorizations in place from that former employee if necessary.
Yeah, no, I completely agree. And then we have to be careful here too, because, you know, this is the employer soliciting the information versus the employee or the patient. because patients have access that sometimes employers may not, depending on what the regulations are. So first and foremost, I'd definitely reach out to your risk management or your local in-house counsel, because that's going to be very specific as well, who owns the data and what kind of data. And I've seen cases where the data is not even completely yours to begin with, because you might have scanned in copies from a specialist, or they somehow got MRI copies that you didn't order the MRI. So be careful what records you're releasing there too, because if it's not yours to begin with, there's questions on how long you're supposed to maintain it. The information blocking rules do not address how long you have to keep it and whatnot for. So I think, record retention is another question that you need to look into the policies, whether it's OSHA, the 30 years plus after employment, then it's very different too. So I think it really depends on the scenario there, and it's very fact specific.
Yeah, real quick, the record retention, Kenji, that is just a critical aspect, especially now with these information blocking rules. So, for example, OSHA's got your 30 years, but let's say it's not an OSHA record, you do on-site primary care or some type of non-OC health services, for adults at maybe only 8 years. And so do you really want to have those records for 10 years? And then when the patient requests the records, you actually have to give them and deal with all this because you have a requirement when you never really had to keep them that long anyways. And so really thinking through the record retention there and having a strong policy. And I think now is a great time to update those policies. If it's an employee that was fired and you think there could be potential litigation and they're claiming you like a disability claim, that's going to be different too once you get the anticipation of litigation from a record retention. So great point, Kenji.
Great, thank you. Jeff, I'm scrolling through the Q&A here. I think we might have one or two, and we only have about 3 minutes left, I think. So this might be the last one.
Okay.
Alicia's asking, in a hospital setting, does this apply to info that's modified frequently, such as handoffs or sign-outs, or say sticky notes in an ambulatory setting? So sort of.
Yeah, I don't think your sticky notes. We could spend a lot of time on this one. Is the provider walking around with a notepad taking notes that really should be put into the EMR that they're making clinical decisions based upon? Or is it like in the hospital setting, this person needs their sheets changed, right? And the sticky notes leaving, like nurses leaving it for, the janitorial staff or something. So I think it's really going to depend on what type there. But if it's anything that clinical decisions are being made or based upon, or anything that should be part of what's considered your designated record set, then it needs to be in the EHR and these rules apply. Kenji, any thoughts there from more of a practical, like operational hospital standpoint?
Yeah, no, absolutely. Because, and I think it was in Stephanie's slide too, documentation. Because if you didn't document it, you didn't do it. So it goes the reverse way as well. Because if it's not in there, that means it happens. So be careful with sticky notes. Because I've seen people do that too. It's been efficient sometime, but if you don't document what you did, it becomes an issue later. So trust me, it's good practice and best practice to document what you do.
Yeah. Hey, Emily, I saw two other questions that aren't in the Q&A. I think they're in like the chat maybe to me that I can answer in like 2 seconds if you don't mind. One was, does this apply to mental health clinics? Yes, it does. And then 2, the COVID question, I thought we might want to hit on real quick because that was a really important one. Let me see if I can find that.
Oh, Stephanie, it was higher in the chat. Yes, please go.
I found
it. Yes.
If a company pays for or offers free home COVID tests to employees and the employees take them, are the employers allowed to access the patient results because they paid for the home test? No. No, you cannot. And so if you want access to those results, you need to have a HIPAA compliant authorization, likely for those. And then also there's other issues from like an ADA perspective on accessing medical information that get into some complex issues with the COVID testing. Kenji, any thoughts there?
No, I completely agree. And this stems to the other biometric, especially those of us who have well-being as part of your occupational health clinic. We have to be careful there too, because some of the biometric data is separate from that and it's treated like similar to the COVID. Your employer should not have access to that at the individual level. So any kind of wellness data, especially EEOCs, having some rulings are behind this now on wellness programs and how it needs to be structured appropriately so that we don't have any of that kind of data available to the employer.
Yeah, and I think I know we have like 1 minute left, Emily. If you have a consultant's notes in your EMR from a referral, are you required to release those records? If those go into your EHR and they are part of what you're making the clinical decisions on, yes, that is all part of the patient's record. So yes, I would include that in any access request. Okay, I'll stop now. I don't even get through all these. Too many good ones
Right.
here.
Yeah, and unfortunately, we're out of time, but it's obviously been a great discussion, great exchange of ideas. I want to thank our panelists, Stephanie and Kenji and Emily. Really appreciate you guys preparing and sharing, some of your insights here. Very well done. Thanks to everybody for attending today as you try to determine how these new rules are going to impact your organization and how you're going to approach sharing health information with your employees. Early next week, we'll send out a link with access to a recording of the webinar along with follow-up material. We will include contact information for Stephanie and Kenji as well if you want to follow up with either of them on any legal questions. And again, I think this is one of those where it's time to dive in and get the right people in your organizations together to start parsing through this. And certainly if anybody has any technology questions that they want to understand how technology can support, actually complying with all of this, we'll be happy to answer those as well. So again, thanks to all of our panelists. Thanks to all of you for attending. Great attendance, great questions. We appreciate it.
It's my pleasure. Thanks, everyone. Bye.
Thank you. Bye.